Welcome to this very special edition of the KAJ Masterclass Live, the show which ensures that you profit from your time spent here with experts, either through their industry insights, information, or simply learning from them. And today we have with us Dr. Eugene Manley Jr. He is a cancer scientist, health equity strategist, founder of the SCHEQ Foundation. So we learned from him the critical intersection of AI, cancer, lung cancer, and racial disparities. And we'll examine how algorithms can quietly worsen outcomes for black and underserved communities. And we'll learn about practical tools for patients to advocate for themselves. We'll learn about complex science in plain language. And we learn also why he argues why diversifying STEM fields is an upstream strategy for saving lives. Welcome to the show, Dr. Eugene.
Thank you so much for having me on. It's a pleasure to be here.
You are welcome. Welcome to the show. Welcome to India in this online form, Dr. Eugene. And I'm sure not just in India, but a lot of people across the globe will benefit from what we are going to talk right now. We'll talk about AI, we'll talk about cancer, we'll talk about health equity. We'll talk about a lot more than this. But before that, let's talk a bit about your journey, your background, so that the audience knows who they are listening to.
So, short version is I'm Dr. Eugene Manley Jr. I'm a mechanical engineer, biomedical engineer, and my PhD is in molecular and cell biology and biochemistry. So, a lot of my work spans musculoskeletal biology, biomechanics, and different approaches for characterizing and understanding tumors from a cellular to systems level. I grew up in Detroit, inner city, first gen, and just saw how healthcare was and wasn't delivered to my family. And then as I was going through academia, I saw the pros and pitfalls of mentorship and training programs. And so I took all of this education and decided to launch a nonprofit that focuses on teaching diverse scholars how to get in and navigate STEM fields, how to get in the workforce and provide resources to help patients understand disease, and then also to create materials for patients to advocate for care to reduce the disparities that they face.
Absolutely. So, in a common person's language, how should they understand what you are doing? What is it that you are trying to achieve with all the things that you are doing?
The simplest version is I want more diverse people to know they can go into STEM fields and have careers. And I want patients to be able to advocate for care that they are entitled to receive.
Absolutely. Absolutely. So, let's talk about the patients here because, in terms of patients, especially you talk about cancer care. I thought we have reached a stage in today's time where there are many options available, where even artificial intelligence is trying to solve some of the problems that can be solved for medical science in terms of data, in terms of analysis and all, and more. And here we understand that perhaps AI can be some sort of uh, disparities, creating some sort of, help us understand from that point of view, what do you exactly mean by that? How can people, I thought AI is very neutral, it does not know anybody, it only knows the prompts.
So the easiest way to describe the role of AI in care, so AI is basically at its root an algorithm. It is using data, using data that's already out there to then make predictions about how either a person may behave, may respond, or may react to a therapy. However, many of the data sets or data compilations that are used are built on non-diverse populations. And so many times you have someone saying, we have this intervention, we can solve this problem. However, if the data is only built on one population, you will never really have a true impact. For example, there was a group that wanted to say they had an algorithm that could detect breast cancer, looking at mammographies, really looking at breast density. And they proclaimed that we have this great solution. And then you look at their data and their test set and training set, and it's affluent white women that are at a suburban hospital. And that's both your training set, which is what you train your data on, and your test set. You missed the whole point of dense breast and cancer disparities, because it is well known that Black women tend to have dense breasts, and that is why they're at greater risk of breast cancer. So if you have not included this population at all, or even thought they matter, then there's no way you're going to be able to capture them with that algorithm. So this is where, while AI has some great purposes, when you don't comprehensively think about the people that it's going to work or benefit, you can really exacerbate disparities.
Absolutely. So, what sort of AI are you talking about? Now, AI is a very wide in context concept, as well as people, general people like me who would look at AI from a Chat GPT or Claude or Perplexity or Deep Seek or any other sort of a thing. Are you talking of those, or you are talking of it? But they are all global in nature,
They are
or
all
you are talking about some other sort of artificial
they're
intelligence.
all AI. It's just how they're implemented and used. So Chat GPT already and similarly builds on the data and content that's already out there. So it is really not a lot of representation in that data. So you always have to take stuff with a grain of salt when you read it or analyze it. Now, if you have a company that creates an algorithm that is specifically focused on a disparity, then it's more likely to be applicable. But at the moment, the way funding generally goes, the person with the brightest ideas gets the funding, but they often don't have diverse teams, diverse staff, or people from these underserved communities. So these communities always get missed. And even if you look further in the past, even our major data sets like our TCGA genomic data sets and our genomic associated studies, GWAS studies, they're all primarily based on European data. And then it's hard to then translate that to then what's happening in Black or Hispanic or other underserved communities, because they're not represented in the data sets. So we already have data that is not reflective. So we have to change the data we produce and how we partition it to really, really solve these problems.
Right. So, those people from where this data is originating, I'm sure those are very smart people. They know that this data that they have is, the outcomes are not very great in terms of what the algorithm is coming out as. Are those very smart people also not smart to find solutions, or to actually work towards finding solutions? Or is it intentional? How would you want a person outside India or anywhere else, even in the US, who may be not too much clued into these things, to understand this?
I would say it's not necessarily always intentional, but you look at who gets the funding, who gets the seed rounds, and it's typically not those working with or from underserved communities. And so you can always run and say, we have a solution. But the question is your solution to a problem that needs to be fixed, or is it just a solution to get you money? And that's a different question. So a lot of people have solutions to make money, but you don't think about the whole part, like how is it broadly applicable? So sometimes it's intentional, sometimes it's just ignorance, but either way, it requires people to use due diligence that often seems to be lacking.
Right. So, in terms of, patients, then, how do they advocate? And before that, let's understand that you talk more about lung cancer. Why is it? Is it only because it's your area, or is it because lung cancer is very predominant?
I'll do this two ways. I primarily talk about lung cancer because that is the bulk of my training. So I've done a lot of work in cell culture, animal models, some studies looking at surveys with patients about their experience navigating care. But that doesn't mean I don't discuss or talk about other cancers. Lung is my specialty. And I'm on a lot of advisory panels about lung, but also lung cancer is the leading cause of cancer death in the US and worldwide. And while that is true, it still receives less attention and funding than colon, prostate, and breast cancer altogether. And the other issue with lung cancer is there's still a massive stigma associated with lung cancer. Like in the 1980s, we did a lot of these very strong, powerful anti-smoking campaigns, but they had such graphic imagery and representations. And unfortunately, while it did do a great job, at least in the US, of reducing smoking rates, it subconsciously made people think that only people with the history of smoking get lung cancer. And so what happens is then people victim blame those with lung cancer, say, oh, well, you deserve to get it. And well, we don't care about you, or we're not going to help you. And then they're ostracized. Whereas in reality, maybe only 60 to 70% of lung cancer is due to history of smoking, but there are people that have other risk factors, radon exposure, indoor cooking modules, firefighters, if you live near a lot of forest fires, these are all risk factors that aren't in the screening guidelines. And there are a high number of Asian females with no history of smoking that we also seem to have massive disparities in, and we don't even know why they get lung cancer. So this is why lung cancer is such a pressing disease. There's lots of issues. And on top of that, since 2003 roughly, lung cancer has been leading a lot of the precision medicine in cancer. Since then, we have about maybe 10 to 11 biomarkers for lung cancer. We have multiple lines of therapy. And so it is now extending lives before what we could do then. Because before 2003, we only had really chemotherapy and radiation. And now we have multiple therapies that keep people alive. And some of these have indications in other diseases. And this is based on the work in lung cancer.
Absolutely. So, what are organizations and people like you doing about it specifically? Because a lot of people say we serve underserved population. We work for the black population. What about those people?
So my work, while I work to educate Black and Hispanic and other underserved, my work is still broadly applicable to the general public. Yes, we haven't, sometimes we have an audience that we target. In particular, I chose Black communities and Hispanic for lung because there's really no information and resources for these patients. There are a lot of great lung cancer organizations and nonprofits, but they tend to be focused on well-off populations that don't tend to have a history of smoking. And so the patients still don't feel seen or heard, or they go to those meetup groups, but then they don't really feel community. Those patients in those external groups, they get information and trials and therapy access that the Black and Hispanic and other underserved never get. So I try to bring information to them from the lens from which they can absorb it and see themselves represented in the materials. We do a lung cancer summit that brings diverse populations together so they can learn more about the disease and how to advocate, and introduce them to people, whether locally or nationally, that may be able to help them or a friend navigate the disease. So my work in lung was partly built by my training and background, but then just seeing the massive disparities that exist.
Absolutely. How are you helping patients here?
So we at Shack Foundation, we do multiple things. We develop infographics to break down medical information. So we have a set of infographics that break down just medical terminology. And this was partly inspired by my mother navigating care and not really being able to understand or read my charts. So I said, how do we break down this information to make it digestible? We also do infographics for cancer. So we'll do like endometrial cancer, and then we'll do a disparity in that cancer. And for the disparity, we try to have some kind of diverse community or representation so that the people can see themselves and understand how to engage that information. And we do some lung cancer webinars related to education and disparities so they can get a better grasp of how to navigate and ask questions in care delivery.
Absolutely. What about patients? How can they best advocate for themselves? Patients as well as their, near and dear ones who are taking care of them.
This is always the challenging part. When you have a cancer diagnosis, your world is turned upside down, and the doctors will give you this massive booklet, which you are just going to be overwhelmed, and you're worried about your life, your job, your insurance. Will you get kicked off insurance? So, if you can get your hospital or clinic to give you a patient or nurse navigator, that will save you a lot of agony because they are typically the bridge between the clinician and the patient. But if you don't have that, then you do need to find organizations that have information and resources. You probably try to find meetup groups. You would try to find communities of people that have navigated the disease. And sometimes you're just trying to ask questions. Sometimes you just need support. And the challenges that caregivers face is even, for lack of a word, it's underappreciated, because caregivers often maybe the only one with that patient. And then the patient is upset and lashing out. And the caregiver has to take all of that abuse, for lack of a better term. And then often they end up leaving or losing a lot of their lives because they become a caregiver. So there are multiple factors that really influence that care and navigating the treatment phase. So this is some of the things, but find meetup groups, find patients. Hopefully some orgs have what they call a buddy program. So they will match you with another patient that has had that cancer. And so I think Emmerman's Angels is good at doing stuff like that. And I think Cancer Support Community does stuff like that.
Absolutely. So what are few things that you want administration, government, and whoever is responsible for this can do so that you're as if you don't require to work so hard for this?
What I really would like is for, more comprehensive information for patients, really more availability of resources, really being able to listen to their needs. And this whole obsession that if you don't make it at this time, you're non-compliant. We have to get rid of that term because often these patients that are navigating these appointments may live far away. They may be frontline jobs where they just can't just take time off and go to a hospital appointment. And sometimes if you're reliant on transit because you're underserved, then if your ride doesn't show up or they say they show, but then you can't really get to an appointment. So they have to really take into account what these people are navigating and facing and not just getting to the appointment. There's often, work and income and, multiple modes of transit.
Right. Does STEM has any role in here? You talk about STEM quite a bit.
Yes. So if we talk about STEM as a career field, this is where we, upstream, the downstream is the workforce and who is seeing the patients, but we don't have a diverse workforce at all. And this really starts as far as elementary, primary school. We don't really do a good job of educating and empowering diverse kids to let them know they can go into STEM fields. And then if you don't do this at an early age, then it's harder to get them engaged in this stuff after they're 10 or 11. So part of my work is trying to create posts for Black History Month and Hispanic Heritage Month. So they can see people from their communities that have done stuff, whether they have degrees or not. These are people that have done work. Then as we help you navigate and get into college, not just getting into college, but helping you navigate that college, those degrees, the degree transitions, like is it master's, PhD, postdoc, why you should do it, thinking about what career paths you can take, because often you only get told you must go to academia if you're in a program. But there's nonprofit, there's government, there's industry, there's science writing. So trying to, develop mentorship and training programs so they can understand what options, what full set of options they have so they can be in the best position for what they want in their career. Because if we can get more of them to then get these degrees and get into the workforce, then we have more people that are actually able to advocate for these underserved communities, understand that lived experience, and then hopefully get rid of some of that implicit bias that are in hospital and other systems because there's no one from these communities there that can advocate for these people.
Absolutely. One last question I want to understand from you, Doctor. Eugene, is that, in terms of AI, how long do you think that the data reset will need? 2 years, 5 years? There has to be a time when AI truly represents the right kind of data that can be helpful, and that there is no disparity, any more disparity created by algorithms.
I don't know if we'll ever get to a point where AI will be so great that it will solve all disparities, because it's still built on the data that's supplied, and we don't have enough data from diverse populations. We don't have enough diverse founders that are developing AI. So I don't know if we'll ever get to that point. We can use AI as a tool to sometimes help make clinical decisions. I'm not saying that all AI is bad. It is not. For helping doctors doing like medical charting, like when they're at the end of the day, and they can do speak to text that helps them get stuff out faster. If you look at robotics for surgery, sometimes that helps the doctors do minimal incisions, keeps the patient open shorter times, and they can have faster recoveries. Sometimes it can help predict whether a patient will be readmitted, and you can just sort of look at maybe including social determinants of health factors. So there are good cases for AI. It's just at the end of the day, AI still will never replace that human interaction with the physician, and it still won't make sure you have all the correct data. So we just have to make sure we are putting those guardrails in place to ensure that everyone that should benefit is included.
Absolutely, absolutely, Dr. Eugene. There is so much to learn about all this, and I'm sure a lot of people would want to connect with you, either for information or taking any help. And I'm sure, what is the best way for them to do so?
They can find our website, hccpscheck.org. You can also follow up, email us info@check.org, and, reach out if you want us to develop a workshop or training program or intervention to help you implement or scale a mentorship training program or a health equity intervention.
Wonderful. With this, it's a wrap on this very special edition of the KAJ Masterclass Live. Thank you so much indeed for joining us.
Thank you so much for having me.